Thomas present this, I'd just like to introduce, maybe you can introduce yourself, but just briefly, that Thomas and Welling is, Welling is Indonesian. She's graduated from Atmajaya, so they are actually husband and wife. So that we are lucky that we're gonna have 2-in-1 presentation by only one visit. So again, thank you for being guest lecturer, and hopefully your presentation can be finished by about 40 minutes, I hope. And then we're gonna have a short discussion, 10 minutes for question and discussion. So please, time is yours.
Well, thank you for the introduction. So I'm Thomas, I'm from Netherlands, where I work at the Julius Center. So basically this is where I work. And so I'm an assistant professor. I mostly do methodological research for prediction models and for meta-analysis. And so today I would like to give a short talk on how we can use meta-analysis methods for making better prediction models and for getting a better understanding into how these prediction models actually work. So for those of you who are not that familiar with risk prediction, so I can tell you, you actually are familiar with it because many of you are actually doing it either on a work basis or at home. And it's all about making predictions about today or about the future. And so in medical research, it's also often about assessing somebody's diagnosis, so about assessing whether somebody is ill or has a certain condition, or possibly also about prognosis, so trying to assess, will this person develop a certain disease or will he die within the next 5 months or within the next 2 years from lung cancer, for example. So any kind of task where we don't know for sure what's going on, but where we need to know and where we are trying to make a prediction about whether this thing will happen, that's what we call risk prediction. And so risk prediction is really about individuals. So it's really about individual patients, try to make an assessment for that particular patient. And so why do we predict? Well, for various reasons, of course. So when treating patients, often we want to just to inform them, what's going on with them, what's their status, what can they expect for the future, given, what happened to them. But also it can, increasingly often, prediction models and score charts are used to guide treatment decisions because they give us an indication of how serious a certain condition is or how serious it might develop if we don't do anything. And so we use these models or score charts to decide, should we give this patient a certain intervention or a certain treatment in order to prevent that these bad things are going to happen. And of course, prediction models are used for a lot of other different reasons as well, which might be less familiar to you. But they have a very important role in medical research. That's my main point. And so, like I mentioned, prediction is really about individuals. It's about the patients themselves. So basically, we try to combine the characteristics of patients. We try to combine all different types of information for that particular patient into an absolute risk that patient will develop a disease or that patient has a certain disease. And so these characteristics could be very simple. They could be the age of the patient, the gender, whether this patient is smoking or not. They can also be a bit more complicated. So they can be characteristics like things that we measure, right? When a patient goes to a GP, the GP might decide, I will take his blood pressure or his glucose levels. I will measure these things. And this type of information could also be used for prediction purposes. And then especially for the more complex types of diseases, we like to refrain on imaging, like MRI or PET-CT scans. Or you might even take biomarkers and all sort of tests on that patient. And also these results can be integrated by prediction models. And then basically what happens is that, so in the end, of course, prediction model is just a kind of formula, an equation, where we put in all these values of the patient, and then the equation gives us a probability. But somebody, of course, is making these equations. Somebody is developing them. And these equations are often developed using large cohort studies, where we actually follow up a lot of patients, where we do measure all these covariates, all these age and gender and blood pressure, and we take all these imaging tests, and then we wait for 5 or 10 years to evaluate whether this patient developed a certain outcome. And then we use statistical methods like regression modeling or machine learning methods to develop these models. So how do these models look like? So maybe you know this example. So this is a familiar, well-known prediction model, or actually score chart, for predicting a 10-year cardiovascular disease. And so in Netherlands, cardiovascular disease is a really important disease on public health level, because many people die from cardiovascular disease. And although I'm not sure if we use SCORE in Netherlands, it is still a model that's used a lot, I think, in the US. And so this chart, basically, you can print it and use it in clinical practice. And when you see a patient that presents itself with certain characteristics, you can assess whether he will develop cardiovascular disease within the next 10 years. So for instance, let's imagine we have a woman attending a GP, and this woman is a smoker. She tells you, I smoke a lot. I smoke, 5 cigarettes every day. And then she's about 50 years old. And we can continue. Then you decide you will measure her blood pressure. And her blood pressure is about 180, if I read correctly. And then we can narrow down a bit further. And we measure also her cholesterol level. And in this case, it's about 3. So now you see this score 3 is actually an individualized prediction for this woman who is smoking and has a certain blood pressure. And this score 3, if we look up in the table on the right-hand side, we can see that it corresponds to about 3 to 4% risk of developing cardiovascular disease within the next 10 years. So 3 to 4%. So how important is that? So maybe you might decide, that's not very significant. Let's just, we can send this patient home and just tell her to eat some, to have some exercise or something like that. But when the risk is much higher than that, you can imagine that you might actually want to take more severe measures to prevent cardiovascular disease, and you might actually decide to prescribe some treatments or some, let's say, statins or something like that to make sure that she won't develop any cardiovascular disease within the next 10 years. Now, there's other examples, because the one I just showed you is a very simple prediction model, right? You can print it on a piece of paper, and everybody knows what's going on. But there are also more complicated models, and especially now where we have machine learning and big data, a lot of models are being developed that are less clear about what's going on. So one example is Watson. It's developed by IBM, and so they have one model for oncology, or it's a series of models. And well, they claim so that the aim of Watson is to bring personalized evidence and evidence-supported cancer care plans for your patients. And so what it does, it actually, like any other prediction model, it will interpret patient characteristics, and it will link these kind of characteristics to information from scientific publications and medical guidelines and so forth. And then it will combine all this information to make a personalized recommendation on how to treat this particular patient. And so this model is actually already being used by several hospitals. So people are actually relying on this machine to treat their patients. Now, unfortunately, to some extent, there are some problems with this machine. And so several people have written about this, but basically, so some of the issues that you can imagine, well, this machine was developed in the United States, so all the data that has fed this machine are basically patients from the United States, and you might wonder whether these patients are representative for patients somewhere else outside the United States, let's say Indonesia. And I think one of the important issues that people have found is that there have been occasions where this machine has actually recommended treatments that are unsafe for the patients. So where actually, if you would have listened without thinking to what the machine was recommending you, you might actually have done harm rather than improving the life of the patient. And so basically what my point is that it's really important when we are using all these prediction models, whether it is Watson or any of the simpler models like SCORE or other score charts, we need to be sure that these predictions that these models are telling us, whether they make any sense, whether they are reliable, and whether they indeed improve patient care. And so we know already for many years that, a famous quote says that all models are wrong, but some of them are useful, right? So, I mean, one way to look at this is to say, forget about the models, let's not use them. But in the end, the goal of these models is to actually improve things. And the real question is not whether we should use them or not. The real question is which moles are useful and how useful are they? And that's really something that challenges us a lot as researchers over the past few decades. And so many people have thought about what defines a good mole and how can we assess and quantify whether a prediction mole is actually anyhow sensible. And so what is more or less commonly agreed now is that we should check for different features of a prediction mole. And the first of all is its internal validity. So that kind of means when we are developing a prediction mole using data from a cohort study or a clinical trial or electronic healthcare records, we want to know whether that mole actually predicts the outcomes accurately in those data that we used for development. So if I have a data set with 2,000 patients and I use those 2,000 patients to make a prediction score, then I want to be sure that in those 2,000 patients, this mole that I made is performing quite well. So if that's the case, well, that's great, but it's not enough. Because actually what I'm doing is I'm making this model, and next thing I'm doing is I'm telling you should use my model because it works very well in my data. But of course what's important is that not just works well in my data, but it also works well in your clinic and in your setting and in your type of patients that maybe look a bit different than my type of patients. So that's what we call external validity. So we want the prediction mole to be externally valid. We want it to also give us reliable predictions when we apply it in different patients, when we apply it tomorrow rather than today, or when we apply it in, I don't know, the next 2 years. And that's more tricky, of course, to achieve prediction moles that are also valid outside the particular sample that we use to develop them. And then a final aspect that we think is really important is that these prediction moles need to have an impact, right? Because it's all very nice if I'm developing all these prediction moles every day, and I can tell, look, these moles predict very accurately, both in my data and both in your data. But if nobody is using these moles, or if these moles are not, for some reason, not improving the life of the patients, then what's the point of using them? So for all of these different aspects of prediction mole performance and the quality of prediction moles, we need to do different type of studies, and we need to assess and quantify how well these moles perform. And then after all these different steps, we can actually make some statements about, yes, we should use these moles. Unfortunately, in practice, there are many prediction moles that never went through all these steps, and that that were just implemented for various reasons that might be beyond what I mentioned here. So I'll skip this for now. So the real question is really, so like I mentioned, so all models are wrong, right? Because they are a simplification of the real world. But how can we assess to what extent these models are useful, and how can we assess to what extent these models give us sensible predictions across different settings and populations? And that's really where, well, what I would say big data comes in. So that's a situation where we actually need data, a lot of data, to make this kind of assessments. And so I would like to focus today on big data sets because these kind of data sets are becoming available increasingly often. For instance, I've been involved in many collaborative studies where actually hospitals or researchers, they form a collaboration and they say, look, we've been studying this disease and we've collected a lot of data on this disease, and we noticed that you are doing similar studies on a similar disease and similar patients. So why wouldn't we just join our forces and share our data? And then so what happens increasingly often, at least in Europe, is that academics are collaborating internationally, and they're really sharing data from large cohort studies with each other, and then they end up with even much bigger data sets with much more variety of patients from different hospitals, from different regions and healthcare systems. And that's what we call an IPD meta-analysis, so meta-analysis of patient-level data. But there's also other examples. So also in the context of electronic healthcare records. So when you have hospitals that routinely collect patient information in databases, you also end up with very large data sets. And so some examples, so for instance, in the United Kingdom, they have these very large registries where they linked data from many hospitals, where every hospital, they actually share data from their patients and the follow-up of these patients with each other. So what you end up with is, again, databases with millions and millions of patients where you have information on these patients' clinical characteristics, but also their treatment and how their prognosis was over a couple of years. And so when you have these very large data sets, there are many things you can do. And I think one of the most important things that we should start doing immediately is to start validating the existing prediction models that are out there. Because many of these prediction models that are being used, the ones that I mentioned, like SCORE, but there's also other examples in many different disease areas. Just to give an example, because we recently did a review on prediction models for cardiovascular disease, and we found there are more than 365 score charts and prediction models just to predict whether somebody will develop cardiovascular disease. And so most of these models, we have no idea if they're actually reliable. So what we can do when we have these very large data sets is we can start validating them, we can start comparing them, and we can start to quantify, do these models make any sense, and in what type of populations do they give us reliable predictions, and in what type of populations should we maybe not use them at all. And so the key advantage of having these big data sets as compared to having one data set is that we can validate or we can apply this prediction model many, many times in different settings, in different hospitals, and we can try to see is there any consistency into how this model performs, and are there any features that explain why a model is not performing very well in certain areas or in certain districts. And we can really try to quantify and get a grasp of how generalizable are these prediction models and how much impact are they likely to yield in clinical practice. And this is where actually meta-analysis comes in. And so for those of you who are not familiar with meta-analysis, so the actual aim of meta-analysis is to summarize research findings from many studies. And there are statistical methods for that kind of weight the results of each study according to how precise they are. And so meta-analysis has been used a lot in intervention research, where we have many clinical trials to assess how a certain, what the efficacy is of a certain treatment. And then often what happens is these trials are in disagreement with each other because some trials are very small, others are very large, and they are conducted in different populations. And so very often the question is, is this treatment, does it actually work? And then we do a meta-analysis and a systematic review to, get all the trials that are out there and try to summarize their findings. And so we can do the same with prediction models, because we can do the same thing. We can validate prediction models in many different locations and many different studies. And then, of course, the same thing will apply. You will get different answers. In this population, the prediction model works. In this population, it doesn't. And then, so we need meta-analysis to try to understand, on average, does our prediction model work? And what kind of situations does it go wrong? So we need to try to investigate sources of what we call heterogeneity. And so just to give an example, so I was involved in a study with Richard Riley, and they wrote some general guidance on how to conduct systematic reviews of prognosis research, and particularly on validation of prediction models. And to give an example, they validated Q-RISK-2 model, which is one of these 360 models for predicting cardiovascular disease. And this one was developed for the UK. And so what we did is we actually applied this prediction model in getting data from the United Kingdom. And we had data from about 1.5 million patients from a large registry, where we had data actually from many, many, many hospitals, I think 364 in total. So this is kind of a big data set where we were able to validate a prediction model very rigorously. And so what we did, so what you can see in the left figure is what we actually did is we applied this prediction model separately in each general practitioner setting. So there were 364 of them. So we got 364 different answers on how well this prediction model Q-RISK-2 was performing. And so then we plotted all these performance indices on this figure, and actually showing the discrimination performance of the Q-RISK-2 model. And then so what you can see roughly is that there is variation in how well this Q-RISK-2 model is performing across the UK. So in some settings, the discrimination performance is it's a bit lower than in other settings. So in some settings, basically, Q-RISK-2 is very, very capable of determining who will develop cardiovascular disease and who will not develop cardiovascular disease. And in other settings, it has more trouble with making that distinction. But on average, the capability of Q-RISK-2 is quite decent of assessing who will develop cardiovascular disease. And most of the variation that you see is because, several of the general practitioner settings, only a few patients. And so even though there is variation between general practitioner settings, you would, based on this figure, you could agree that despite this variation, we think the discrimination performance is adequate and is consistently high across the entire United Kingdom. So in the past, we would have done, let's say, one study where we just get one number on this is how well the Q-risk2 discriminates in the United Kingdom. And then we would have to assume that that average is representative for the entire United Kingdom. Whereas now, actually, we can investigate whether this Q-risk2 model is consistently performing well everywhere in the United Kingdom. So it's giving us a more detailed answer by having data from so many different locations. And then, of course, we can also look at different features of Q-risk2 performance. So, for instance, on the right graph, we look at calibration performance. So we actually try to investigate, do the predicted risks of Q-risk2, do they correspond to the actual risk of the patient? And so ideally, you would want to see that, let's say, 10% predicted risk of cardiovascular disease is indeed 10%. And if somebody gets a prediction of 80% developing cardiovascular disease, that is indeed 80%. Because if that 80% is not 80%, but let's say 5%, then that's really problematic, right? Because then based on that 80%, you might have decided I will prescribe all sorts of treatments and medications to these patients, whereas that might not have been necessary. So it's really important that this calibration is reliable and accurate across the entire range of predicted risk. And so, well, we actually compared Q-risk2 to Framingham, and we noticed that Q-risk2 actually has somewhat better calibration than Framingham in the United Kingdom, which is not that strange, of course, because Framingham was developed in the United States. So these are some references. So I would just like to move on development of prediction models, because, of course, another thing you can do is rather than validating all the existing models that are out there, is to just make a new prediction model. And of course, given that there are already so many prediction models out there, this might not always be necessary. But there are still several disease areas where there are not that proper prediction models available yet, or where there are just not very good prediction models available. And then having data from many different locations is actually a very helpful feature to improve the field. And so the big advantage, again, of having data from many locations and many hospitals and many settings is that we can already try to investigate how well will this model I'm developing, or this score chart I'm developing, how well will this actually perform when I will be implementing it across, let's say, entire Indonesia or entire Europe, because I have data from all these different locations in Indonesia or in Europe. And so I can try to assess the generalizability directly during the development. And so this is different from what we used to do in the past, where we had a very small data set from one hospital or one general practitioner, where of course we could validate the model and give some indication, this is how well my model will perform. But if I only have data from one hospital, I cannot really make any statement or any assessment how well it will perform in the next hospital or in the next country. So to make that kind of assessments, I actually need to have data from these different countries. So I will just directly go to an example. So one thing we did very recently is that we developed a prediction model for ALS. And ALS is a neurological disease, which is very serious, because people who are diagnosed with ALS, they usually die very fast. So they typically die, I think, within the next 2 years or 3 years. And so it's a very serious condition. And so we combined data from across whole Europe, so from many different hospitals specialized in ALS, and we obtained data from almost 12,000 patients on ALS. And so 12,000 patients, maybe it's not a lot for you, but for people with ALS, that's a huge number, right? Because there are not that amount of patients who have ALS. So by combining data from many countries, we actually managed to get much more effective sample size than you can get in a single hospital. Because if you would visit one hospital, I don't know how many patients you could possibly get with this disease. And so we ended up with data from 14 different ALS centers across the entire Europe. So we actually had a very diverse set of patients from many different countries. And then we developed a prediction model to predict a composite endpoint. So we try to predict to these patients who are diagnosed with ALS, how long will it take, how long will they survive, or how long will it take before they develop a condition where they need ventilation for more than 24 hours a day, or where they will need a tracheostomy. And we used advanced statistical methods to combine all these different types of data sets and to enable the prediction of individualized survival. So to really enable the prediction of prognosis of different patients. And so we adopted a technique that was recently described, I think originally in 2004 by Patrick Royston. And it's a kind of technique where we split the data on a study level. So where we would have, let's say, in this case, we have 14 studies, right? We have 14 studies with data from ALS centers. And we would keep one study separate for validation, and we would use the remaining 13 studies to develop our prediction model. And then we would validate that model in the 14th study. We can iterate that process many times, and what we get then is a kind of, we get many validations of our prediction model, and we can do a meta-analysis of the performance of our model, and we can try to understand, does our prediction model perform well, and does it consistently perform well across all these different ALS centers. And so actually what we found here, so this is just one part of the picture, of course, because this is focused on discrimination performance. So but what we found here is that the discrimination performance of this model for prognosis in ALS patients had a very high discrimination performance. And that, for instance, let's say that if we had a criteria that in order for our model to be useful in clinical practice, we need to have a discrimination performance of at least, 70%. Then we found that actually this model, despite the fact that there is variation across center and uncertainty because of estimation, despite all these challenges and limitations, we have still a 100% chance that this prediction model that we developed would yield a discrimination performance of at least 70% in a new hospital in Europe. So that's quite reassuring. And so what we also did recently is that we applied our prediction model to a patient, you might maybe be familiar with, to see, what was his predicted survival. And so maybe some of you know Stephen Hawking. So Stephen Hawking was a very well-known researcher who developed a lot of ideas and theories on black holes and physics. And unfortunately, he was diagnosed in 1963 with the disease ALS. And so back then, I mean, even now, but back then the prognosis of patients with ALS was very poor, of course. And I think they told him in 1963, that he had to prepare for the worst and that he had probably only 2 years to live, which is very serious. And for some reason, he managed to live a lot longer. He actually was very surprising. He deceased actually this year, earlier this year. And so basically, his prognosis was very long. It's still very exceptional, of course. But so we applied the prediction model that we developed using these 14,000 patients to see, could we have predicted how long Stephen Hawking would have survived if we had this tool available in 1963. And so our prediction model predicted that the 10-year survival of Stephen Hawking would be at least 94%. So we had a 94% chance that he would survive at least 10 years or more. And so actually he reached the endpoint of our prediction model in 86 or 87 when he had the tracheostomy. So in 1987, which is already far more than 10 years ahead after diagnosis, he reached the endpoint, but he still survived a lot longer than that. And so our model also indicated that one of the reasons that Stephen Hawking managed to survive that long is, one of the reasons is that he was very young when he was diagnosed with ALS. So this is also one of the features that prediction models can tell you, is that, based on the weight of these different factors that are in the score chart or in the model, you can give an indication of what are the important features that drive that a certain prognosis is different across patients. So there's more references, and basically at this moment we are doing a lot of research also in collaboration with the United Kingdom and with Richard Riley and Gary Collins from Oxford. We're doing a lot of research on how we can make better use of different data sets and how we can try to get a better understanding of where all these differences coming from in prognosis and in the performance of prediction models. So some of the things we are working on first is software to facilitate the systematic review and meta-analysis of prediction models and to develop new prediction models. And other things we are doing is, of course, is writing publications, but also books on how to, in the new area with big data sets, how to develop prediction models, taking into account that we have all these various sources of data, how to overcome all these challenges of cleaning the data and dealing with missing values and all these differences in measurements methods, and how to do the meta-analysis of these different models. So these are actually 3 books that are not published yet, but they are in well, they're in the process of being published and will probably be available in the next year or 2, I think. So I thank you for your attention, and well, please do not hesitate to any questions that you might have to pose them.
Thank you for the opportunity. My name is Rastati. I'm from the Biomedical Sciences Department. I learned a little bit about modeling in 2015, and I think one of the most important things to have to make a model is you have to think about the parameters that you want to include in the model, and it's very difficult because you need to really think about it and then ask for a lot of experts' opinion and a lot of things. And I just want to ask of the models that you've presented, and I think you were involved in developing the models. How do you do that? I mean, having the opinions from experts and then build the parameters and also having the big data. It's very difficult for us here in Indonesia because the data are scattered everywhere in a lot of hospitals, and many hospitals use different kind of medical reports, and how do you overcome that kinds of problems?
Yeah, that's a good question. So I'll go first on the choice of the variables, because for many diagnostic and prognostic models, of course, we try to implement them in a setting where people are making these diagnoses or these assessments of patients, and they're already measuring things that they think are important, like blood pressure and glucose levels and so forth. So often, many of the variables that we use in or parameters that we use in prediction models are partly based on what's already being measured in clinical practice, and then we try to make a distinction between what are measurements that we can take easily without much cost and effort, and what are measurements that are more invasive or more expensive, like imaging or biomarkers. You don't want to implement them in every prediction model because they're kind of expensive to measure for every patient. So often what we sometimes do is make different versions of a model. One, you could say a cheap version, and one, a more expensive version where you need to combine all these different types of measurements. And then what you hope is that the more extensive model is not that much better as compared to the easier model, or that where you do some shifting based on the cheaper model, and then after the shifting you can refer to more expensive tests. But yeah, I agree. The identification of variables that are really informative is really critical, because depending on what access you have on what type of data and what type of measurements that you have, this will be crucial in assessing on how, ultimately what this prediction model is going to do. Because you might have as much data as you want, you might have millions and millions of records on patient data, but if you don't have access to the right measurements, or if the right measurements are too expensive, then whatever fancy method you let loose on this data is never going to give you a very accurate answer. So having access to key information is really critical. And this is also relevant for dealing with registry data, because often in registries, of course, the quality of the data is not always great. So you have to be very careful in how was this register populated? You know, where did these measurements come from, and which measurements are actually make any sense, and which measurements are, you know, really, really bad. And some of these assessments you can do analytically, but some of it you have to know, right? You have to be involved somehow with these registers to know that, look, I know this, we have data on this variable, but you should not use it because it's really bad. And then a similar issue that we have, of course, everywhere in the world, I think, is indeed the fact that different hospitals, they use their own electronic healthcare system, their own way of, how do you call it, coding different variables, and they have their own databases. And often what happens when we do this kind of collaborative research is that often we have PhD students going from one hospital to the other and trying to, you know, take a snapshot of the data, and then they try to clean it and combine it afterwards. But it takes a lot of time, a lot of effort. And so, of course, in the long run, you can imagine it would be much more effective if you have some kind of agreement into how these registers are being populated and what are definitions for simple things like age and blood pressure and so forth, but also for more complicated measurements. Because if you have some agreement or some kind of common system on how to measure these things, it will be much more easier and much less expensive to, you know, combine data from all these different hospitals. And so what we have also in Europe, and probably here as well, is, for instance, we have definitions for diagnostic codes for, you know, diseases. We have all sort of codes to define, you know, this is a disease and it needs to meet this and this and this criteria, and so forth. But that's for diagnosis. But you can imagine the same for just for clinical variables. We also need something like that to make sure that when I'm combining data, for instance, just on cardiovascular disease, when I'm combining my data with your data, and you say, yes, I measured blood pressure and smoking status and so forth, still there will be a lot of differences between how I define smoking status and to how you define that. And I agree, it's a lot of work to try to make, you know, to make sense of these kind of differences.
Yes, sure. Okay, my name is Agus. My current interest is now on global warming, climate change, and tropical medicine. Okay, we do need a lot of data to design finally a certain model which is applicable and could be generalized, right? But I still have difficulties in deciding what kind of models are appropriate. You mentioned briefly concerning meta-analysis. I have very large doubt whether meta-analysis could help or support these models. Can you briefly elaborate the role of meta-analysis on creating model?
Yeah, so I think so, because in the first place I wanted to elaborate a bit on the role of validating models, right? When you are developing a model, you can use meta-analysis to get a better understanding. Does my model work? You know, does it predict what it should be predicting? Not just on average, right? Because on average, it's quite easy to predict something that seems to work quite well on average. But if your model, maybe I should just go to one of my slides here. Yeah, so what would be a good one? So let's maybe take this one. So let's say, so this is a model I developed for a disease, or a very simple model. And I've applied it in different countries, right? I applied my model in different studies. I applied my model in study 1, in study 2, and so forth. And I get very different answers on how well this model performs. So rather than applying my model in the combined set of all different studies in one very big data set, I actually applied it locally in Netherlands, in Germany, and so forth. And so what I see is that if I would just take the average country, or if I would apply my model in an average country, it works, it predicts quite accurately. But if I look more closely, individually, I will see that my model predicts very badly in Netherlands, and it also predicts very badly in Germany, but in another way. So on average it works, but actually if I look individually, on individual level, it performs quite bad. And so where does meta-analysis come into play here? So what I'm trying to say is that if we are validating models locally in different settings, somehow we need to summarize again the answer, right? We need to summarize what's going on. If I have these 100 different pages with validation results from 100 different countries, I need to have a summary answer on, what can I expect from this model. So meta-analysis can give you that summary, but it can also tell you beyond, on average, how well does my model perform. It can also tell you how much variation is there in the performance. If I was to apply my model in a different country, let's say in the United States or in Japan or something like that, what can I expect how that model will perform in that new country that is different from the average country. And so meta-analysis can really quantify how generalizable your prediction model will be, how much deviation you can expect when you apply that model in a new setting or in a new country or in a new population. And it can also be used to explore reasons why there is that variation going on. It can be provided with reasons or with features that explain these are arguments or factors that that affect the performance of your model, that affect why your model is predicting very poorly in these different settings. So I see it as a tool to get a better understanding into why things are going wrong, or why, or as a tool to understand or to confirm that the model is indeed generalizable and that it works very well, not just on average, but in all these different settings and locations.
Speaking about big data, is it correct if I conclude that in Europe you have easier access to get all this data as compared to, let's say, certain countries in Asia? I see that you can easily get those data and design a model. Are there any restriction or rules or regulation against accessing?
Oh, yes, definitely.
Especially in health.
Yeah, definitely. So, because now with EU, we have legislation on what data can be shared and so forth. So many of examples that I've been involved in is actually retrospective sharing. So where the studies have already been conducted and where already patients have given their consent to share the data for the research purposes. And so we basically combined data that was already collected for research. But there's of course also examples like electronic healthcare record data, where patients' data is being stored in a hospital database. I can imagine it's going to be much more difficult to collect and combine all this data, because you will need to have some consent from the patients, and you will need to go to ethical approval and so forth. And then there is political issues, because you need to agree with different hospitals that, look, we're going to share the data, and people need to pay for these efforts, right? And so it takes a lot of time. I mean, many of these studies I've been involved in, just to get the data ready for analysis, it can take a couple of years, easily.
Okay. Anyone get motivated to do?
Well, yeah. Let me just add. Maybe it can take a lot of time, but let me assure you, if you have it, if you are there, I think there is a wonderful world that can open. So you just have to be patient and be willing and see the benefits and advantages that it might offer. And if it's not there, well, yeah, then not pursue it. But I think there are many areas where doing this kind of collaborative research can really push the boundaries of the quality and the healthcare where we were at this point in time. It's just that, yes, indeed, it might take quite some effort and some goodwill from different parties.
So I think thank you very much for your talk. It's again underlined that collaborative work is always important. Having big data is good, but how to get big data, because in Indonesia, as we discussed before, is very challenging. And I guess the methods is available for doing that, but maybe for us, for clinicians, I think it's good for having good friends and have a good working together is always better than working individually. Right? Have a practice, individual practice is good, but join the data from the whole practices from Indonesia is perhaps amazing. Okay, thank you, Thomas.
Thank you
for your presentation. Now we are we'll jump a little bit into a different topic. Well, everything is connected in epidemiology. We are studying about the determinant of the disease, right? And our topic, in the second topic here, is about rather on infectious disease. And please welcome Welling to present your presentation. Okay, the time is yours.
Thank you again for the opportunity to present and share my work. And as Pak Yayan already mentioned in introductions, I'm Indonesian. I'm originally from Jakarta. I'm a medical doctor by training, but since I moved to the Netherlands in 2008, I've been working in epidemiology of infectious disease. So I'd like to share my latest work in how we use mathematical modeling to quantify the burden of disease of lymphatic filariasis at the Erasmus University of Rotterdam. This project is funded by DNDi. It's a drug for neglected tropical diseases initiatives. So I'll start with introduction of the disease for those of you who are not familiar with it. Lymphatic filariasis, or LF, is a neglected tropical disease which is endemic in many, many countries, including Indonesia. It's estimated that it infects more than 120 million, with 1.4 billion people living at risk. It is caused by 3 different parasites, the Bancroftian, filariasis, and the Bruchian. And these filaria parasites, or worms, are spread by a variety of mosquito species. So if we look at the life cycle of the disease, we can start with the L3. So this is the stages. Can you see the pointer? No. Okay. So the middle, if you see the mosquito, the upper graph, it describes the larva stage 3 of the parasites, which can be transmitted during the blood meal of the mosquito in humans. And in humans, you see the arrow, the blue circle represents the cycle in humans, and the red circle is the cycle in the mosquitoes. So once the mosquito bites a human, it can transmit the larva 3 stage, and then this larva can develop into an adult form. And when they mate, the female and male worms, they can produce many, many microfilaria, and this microfilaria can go back into the mosquitoes during the subsequent meals, and then it will develop further into larva stage 1, 2, and back to the 3rd stage where it can fulfill the circle. So once it reaches human body, it goes into the lymphatic systems. So lymphatic system is a semi-open circulation systems in human body, where some parts the worms can go through the lymphatic vessels, but some parts it just go into the open spaces in the human body. But the research shows that these parasites have some preference for locations for growing further, and that is the axillary and the inguinal nodes, the lymph nodes area. So the aim of my study was to inform the design and quantifications of the morbidity module in a model called LymphaSim, which is used to quantify the global burden of LF. I'll come back to this model later, but I want to show you how we can do a review on a particular disease, for example, here in LF, and use that information we gathered to inform the model further how we can make a better predictions. So if we go to the infections and disease of this LF, we can see that in an endemic area, you can find typically 3 different groups of populations. The first one is what we call endemic normals. So these people remain free of infection or disease, even though they live every day surrounded by people who do have the diseases and bitten by the same mosquitoes. The second group is called asymptomatic. So we know that these people are infected. They harbor either the microfilaria, MF, we call it patent infections, or they harbor also the adult worms, and we call it latent infections. And the third group is what we call a pathological group of populations. They could develop either an acute or a chronic phase of this disease. So it's just an example of the acute infections if it affects the limb or the arms. And this is an example of a chronic form. Then from the most left picture, you can see the effect. The arms, you have a lymphedema of the arms, and if it affects the inguinal area, blocking the scrotal lymphatic circulations, you'll have a hydrocele, and you can also you have the breast lymphedema, or you can have among all of those people getting infected. I did some search in Embase and went line with a predefined inclusion criteria, and just want to show you that from more than 600 records, and we screened the abstract and the full text, we included 26 of studies, and I'd like to briefly mention the results from a different perspective. From a histological point of view, we know that the worms, they actually gave a very little reaction as long as they stay alive in human body. And once they died, these worms died, somehow they triggers these reactions, we call it granulomatose infections, that sort of blockage the lymphatic circulations that cause dilatations of the lymphatic, and further cause the disruptions, and these people can develop lymphedema. Once they develop the lymphedema, they can go further into what we call brawny lymphedema, that is with the hardening and thickening of the outer skin. And when it gets really thick, the skin starts to fold, and in the skin folds, it can cracks and gives a new entrance for further bacterial and fungal infections that affects locally or systemically. So here is the histological images, how it shows. The first one is just a normal skin epidermic structure, and how it is if there's a worm presence. And here, what we can expect when it already reached a late stage of lymphedema. You can see it's no longer smooth, the epidermical, but it comes with the folds, and you can see, I cannot point it out here, but there's a port of entrance within that can trigger further infections and make the disease progress to elephantiasis. And that kind of feature we can expect in this elephantiasis. So this is what we found in immunology, but I will not go into detail. I just want to point out that there are several factors that influence the immunological reactions in the infected individuals. That is age and gender, transmission intensity. So those people who live in an endemic area with a very high transmission will have a different probability of getting or spreading the infections than those who live in a lower endemic area. We also see how these people with different genetics, they also have a different characteristics in spreading the infections. And if we look at the pathogenesis, as also revealed by histological results, that there are 2 different components in LF that is called lymphangiectasia, that is the dilatations of the lymphatic vessels, and also there's a component they found called inflammatory reactions. So that resulted from the dead worms, and these two different components, we call it 2-stage of LF pathogenesis. And the transition from one stage to another is somehow determined by whether this person has secondary bacterial infections. So with the skin folds that serve as a port d'entrée or entrance of bacterial and fungal, they could develop secondary bacterial infections. And once they do have this, the disease will progress faster. And it also depends on the burden, how many adult worms an individual harbor in its body, and the location of the adult worms, and the type of human response, human immune response, and the intrinsic factor such as the age, and the Wolbachia is a parasite living in the parasite itself. So this worm also have parasite called Wolbachia living in them. So whether or not the worms have Wolbachia. So as a summary, we know that there are factors underlying the disease establishment, and you can look at this from human or worm or environmental factors. So what is the current guideline for LF? We know that WHO recommends a primary prevention. So first of all, try to avoid the risk of getting infected by applying anti-mosquito repellent or using a bed net. And another thing is they also recommend a mass drug administrations, we call it MDA, using a different drug regime such as ivermectin, DEC, or albendazole, because they think if they ask all individuals living in the endemic area to take these medicines, they will kill whatever parasites they have in their blood, and then the mosquitoes cannot then transmit further the infections or maintain infections in that area. But of course, once you have the infections, the WHO recommended that we take the secondary and tertiary preventions, that is the morbidity management and disability preventions. So we treat not only with antiviral medicines, but also teach the people how to maintain the hygiene, because you can imagine people with a lot of skin folds, it's very difficult to keep it clean all the time, and if they don't keep it clean, they will have a higher risk of having secondary bacterial infection, and it only makes the disease worse. And we knew for hydrocele, the only treatment is actually surgery, and they also realized how important it is, the psychological and socioeconomic support, because most of people with this disease, they have a stigma, they get really embarrassed and shy, and they get excluded from society, but it actually make them getting worse because they don't know how or where to get help, how to get better, and how to prevent the disease into a worse state. So I just want to show you that the global program for elimination of LF has started since 2000s, which aimed eliminations by 2020. And these are the current MDA profiles for countries. So we differentiate those who have not identified but not started the elimination program, and those who are already implementing but not at scale, and until those who has reached eliminations. Indonesia is unfortunately still at the not at scale phase. So the guideline change from time to time. So for example, just last year we have an existing guideline what drug regimes we should give to these people, but then they issued a new guidelines. We should use a different regime. For example, instead of the just DEC and albendazole, you should use a triple regime, including ivermectin. For those of you working in LF interested, you can look at the new guideline available at WHO website. So we also like to know what is the impact of morbidity management in the LF morbidity. So I also did a second review in the MBase and Medline with the pre-specified inclusion criteria. And from more than 800 studies, I screened the abstract and full text and included about 30 of studies. So we can look at, I just try to illustrate for the primary interventions and for the morbidity management, secondary and tertiary interventions, they do have some impact, although the impacts, the result reported are not always consistent. So maybe at this point I should have tried to apply what Thomas suggested to do a meta-analysis, but we have not reached that far yet. So we know that this LF is an ancient disease with history of changing interventions, but we also know that these several factors could work to stop the transmission and reduce the burden of this disease, such as vector control, the MDA, hygiene care, surgery, and psychosocial support. So the Erasmus team, the mathematical modeler in the public health department, developed what they call LymphaSim. So it combines information from different sources, such as the information from the vector, from the mosquitoes, how far is the lifespan of the mosquitoes, and the biting rates of these mosquitoes. They also collected information on the worm levels, so what is the probability of microfilaria will develop into a larva stage 3, and what's the probability of a larva stage 3 will develop into an adult worms, and then find their mates, and then produce microfilaria. So we also combine information on the human levels, that is the demographic factors. For example, what is the proportion of male and female living in an area with a certain age. So what the LymphaSim does is actually they simulate at each time step what is the probability of an individual worm in an individual human that will develop and transmit the infections in the human populations. So you see, and then we do these simulations like tens of thousands of times, then we can get an estimate, the average of humans that will be infected. So this LymphaSim has been applied many, many times. I'll show you just two examples. On the left side, we see the prevalence of microfilaria in India in 1981. So each box plot represents the estimate of prevalence in the certain age groups, and you can see the lines, different lines, showing different assumptions on immunity, either immunity against the larva 3 stage or the fecundity. You can see that the model actually gives quite an accurate predictions. And on the right graph, you can see how the model predicts the microfilaria prevalence if we do interventions such as the mass drug administrations for 6 times. So the different lines represent how high the prevalence of microfilaria will be if the mosquito has different rates of biting. So if the higher the biting rate is, so you can imagine the transmission will be even higher. So even though you implement the mass drug administration for 6 times, it seems that it could really lower the infections. But if the transmission is really high, the biting rates in this case, the likelihood that these infections will spread again is rather high. So back to the aim of the studies, what can we use the results of the review to improve the model further? So we know that the morbidity is somehow determined by several factors, such as the burden of vocation of the disease, of the worm, and the transmission intensity, and whether or not these worms have a parasite we call endosymbiont, that is the Wolbachia. And on the human levels, we also know that they depend on the age and gender, genetics, and immune response. And somehow, actually, most of these factors are already included in the LymphaSim model. But what we want to do further is actually from the transmission of infection estimates, we want to estimate further the morbidity, because in the end, we want to know how many people are actually will develop the disease. Because the disease is actually what's caused most of the burden. So from the second review, we know that if we do certain interventions, such as vector control or MDA, we can actually disrupt the transmission from the parasite cycle, and from the human level, we can do a certain intervention, such as medications, hygiene, surgery or even psychosocial support. And from this review, we can also think further into a more detail, such as which mechanism actually should be added when we want to expand the lymphocyte model, and should we actually make a model for a specific morbidity manifestation? For example, do we have to make a different model for lymphedema and for hydrocele, or can we just use actually one model? And we also like to think about what is actually the effect, the long-term effect of the disease management on the disease progression. Is it actually modified by the coverage of the intervention? And how should we consider the effect of primary intervention in the morbidity module of the lymphocyte? So this is a proposal what we would do with the lymphocyte next. So we want to distinguish two types of model. The first one is tries to describe the lymphedema or elephantiasis, which is A side, and the B is we want to quantify the burden of the hydrocele. So it looks rather similar, but there's a difference from the lymphedema and hydrocele, especially, well, I'll start with the bottom one. For those who are individuals who get infected, at some point when the worms inside of these individuals died, they will develop some symptoms. For the lymphedema on the left side, once they reach the early of lymphedema stage, it is irreversible, so they cannot go back and then somehow get healed by the nature course. And they can only go further to the elephantiasis state. Although the speed of progressing from one state to another is always variable, and yeah, that's what we want to know with the model. And for the hydrocele part, we know that even though these individuals who have the worms dead in their body starts developing symptoms such as hydrocele, they amazingly, more than 70% of them could still resolve and get back to normal without any interventions. And only 30% who will develop a late hydrocele will need interventions such as surgery to improve their health. So that's more or less the introductions I'd like to share with you guys. If there are any questions, I'll be happy to accept.
Any question from the audience? So you do a systematic review of literatures and finding articles and extract information from that. For how long you do that? Or only collect, from the beginning to the conclusion?
So we have a project, a one-year project to do the review, and then we use the results of this review to inform the model. At this moment, we are actually improving the models. So, and we're trying to use all the information from the reviews to feed the parameters, and we will in the future. So, answer your questions. The review took 1 year, the 2 reviews. And then what we're going to do next is try to fit the model using the information we have from the review to predict the burden of the LF morbidity.
So, if I'm not mistaken, there's two steps, right? So you have literature reviewers and collect some information. Then you think how it's fit, how it help to improve the lymphocyte, right?
Yes.
Lymphocyte model. Okay. I'm just trying to tease the audience, but maybe Prof. Widad again, because Prof. Widad is actually, Prof. Widad Agus is expert in filariasis.
Thank you. My name is Widad Agus. Speaking about lymphatic filariasis, it's like walking down the memory lanes. I used to be a parasitologist, but already move on. So move on. I changed into an epidemiologist, and I'm now currently studying more principles into your model. Number one is that actually in Indonesia there are 4 types of filariasis. As you mentioned, the Brubiamai, and then the Buccaria bankruptcy, and then in East Timor, Bugia Timor.
Correct.
But there's another kind of lymphatic filariasis, but not in human. It is a very zoonotic. It is called the Brugia kalimantani, discovered by Dr. Palmieri from the Namru U.S. Army Research Unit. It is not very important actually, but you have to put in mind that there are other filariasis beside that infects humans. Okay. Number 2, these filaria is a species specific. Certain area of the country only have 1 or 2 species. Sometimes they also mix. Like for instance, in Sumatra, there are more prevalent having Brugiamai. Also in the peninsular Malaysia and northern Malaysia, Sabah and Sarawak. So maybe you should also put some note on the control and eradication of the disease. And number 2, we have currently no so-called modern drug. What we are using, what the WHO are using, is still the old drug called the DZ, right? And DZ causes a lot of problem because of the side effect. And then the community, how should I say, are reluctant to take the drug because of the side effect. And this causes the program not to be effective in certain area. Let's say for instance, I'm now currently sitting as the board of advisor to the Ministry of Health on how to eliminate filariasis in West Java. And the people, the community in Java refuses to take this drug. And mosquito control is also difficult. That's why when WHO mentioned that filariasis will be eliminated in the year 2020, I place very high doubt. Better if I say that WHO is wrong, and then my prediction is that in Indonesia at least, filariasis can only be eliminated and can only be eliminated in 2030. You see? Maybe people in Geneva say that it is easy to control this problem in Indonesia, but not in this country. Okay? So unless you have a better priority in the Ministry of Health, the elimination of elephantiasis is maybe the priority is very low, and then the community is also reluctant to support the program. See, okay, maybe we should talk in private maybe later on, but I think you have to add some more consideration, not only in a certain area of the Southeast Asia. It's important to have this model revised again. Okay, perhaps in Africa you can do that, but not in this area of the country. Okay, thank you.
Yes, thank you. Try to respond to several points you mentioned. If I miss anything, just please remind me. It's actually correct. It's a well-known problem, the uptake of this MDA, the mass drug administrations, in many endemic areas, not only in Southeast Asia or Indonesia, but also in Africa, because some drugs do give some side effects. That's why actually part of the recommendation is that in addition to just giving the drugs, you also have to teach. So you also inform the community. They might be some side effects, but these side effects is only temporary, and for the greater good, they should really take the medicines, because if we were to believe the model estimates, it actually requires only like 50% of the uptakes, and we can actually stop the transmissions. But in fact, the uptake is very, very low. It's only like 30% or even less. That's why what they predict in the beginning, that it only takes 3 rounds, apparently took 5 rounds and still did not manage to eliminate the disease. Would you like to? Yeah. And what I want to say, so I cannot speak on WHO behalf. I don't know their recommendations. We do work together with them. We try to give our advice and based on our model predictions. But and again, I cannot say what they should recommend this or that. But this model has been applied to different types of filariasis. So not only the Bancroftian, but also the Bruggian. We use many data from India, in Indonesia. They are now collaborating, I think, mainly with the University of Indonesia. So they use data from many parts of Indonesia to predict the transmissions and whether or not the interventions will stop the transmissions. We realize the reaching the eliminations by 2020 is rather optimistic, and we could never reach it. So part of the project, which is funded by the NDI, to actually make a more realistic estimates, like, okay, in the past we predict we should reach it by 2020, but it's only 1.5 years to go. There's no way we could reach it. So some countries do indeed need longer time. So they actually ask our advice, how much effort should actually do more, and when can we actually expect the eliminations. So for some countries, they already said it's going to take even longer than 2030 to reach eliminations. But I don't have the results of the estimates per country profile, but I know some countries do need more to reach eliminations. And if you say that the different areas have different problems of filariasis, that's absolutely correct. We know that here in Indonesia we have also the Timori, which is only prevalent in Timor, not anywhere else in the world. That's why when we want to develop further this model, we want to look at, but not on species level, but more on the morbidity level, because we know some types of species will give more burden into the form of elephantiasis, and the other types will give more burden in terms of hydrocele. So we distinguish in that sense. So not on the species of the parasite level, but on the morbidity level.
Regarding to Wolbachia, you mentioned a little bit about Wolbachia, right?
Yes.
A lot of researchers are, I think, doing some study that are wrongly directed. I mean, people are thinking about controlling the mosquito by genetic manipulation to change the character of the mosquito. But I think my idea is to start searching the Wolbachia inside the worm. The worm survive because Wolbachia exists inside the worm. Okay, so a lot of research effort should be directed to looking into the characteristic of Wolbachia inside the worm instead of the mosquito.
Yes, I agree. There are actually a lot of research looking into the role of Wolbachia in causing disease, and they actually believe that it's the Wolbachia that caused the disease instead of just the worms. But recently, there are also studies being published try to counterfact that results, because they know that Wolbachia exists not only in lymphatic filariasis parasites, but also in other filarial diseases. And when they do control this Wolbachia, they don't see the disease. I mean, they still do see the disease. Let me try to think. Yeah, but they did. I just tried to say in some studies they really look into the role of Wolbachia, and they try to say like, yeah, if we administer, for example, doxycycline to kill all the Wolbachia, then these people should not develop the disease. But when they look further into detail, some other research they say is like it doesn't really matter if you control the Wolbachia or not, you still develop the disease. So it's still in the debate whether Wolbachia plays a crucial role, or it's just like a coincidence that Wolbachia exists and somehow gives a collateral damage to the people harboring the adult worms.
The concept or the idea of doing research on Wolbachia is one characteristic of the Wolbachia is that this bacteria is able to change the sexual preference. I mean, is able to, how should I say, I am not too good in my English, feminization of the host. A lot of male worms will be turned into female worms, and these female worms will produce a lot more eggs, something like that. Also in the mosquito. This is what we call in the field of microbiology, Wolbachia is a superbug or superbacteria market.
Yes, I agree with you. And as I said before, it's still a big debate about the role of Wolbachia. What we try to facilitate in our model is the moment when the adult worms die, because that's actually the moment that makes the difference, right? Because the Wolbachia stays in the worm, even though the worms are treated and the Wolbachia killed or not, it doesn't cause any difference until the moment that the worms die. Because the moment the worm die, they will release all the Wolbachia into the blood and then cause further problems, reactions and problems. So we try to facilitate that stage into the model by stating that stage, the death of adult worms. Here, the second level.
Thank you for the discussion about the agent and the factor. I'd like to ask about the host, in this term the human who infected, but also the potential infected. Because I have a student, he is a head of a Puskesmas, primary healthcare, in the south part of West Java. The thesis is about the filariasis. Doing education, door-to-door education, to take prophylaxis yearly, door-to-door. So doing in 2 villages. So one village increased to like 60%, the other villages 80%. So the education is about, so he took the health belief model. So the health belief model means that how people perceive whether the health is important or not. In these terms, taking the prophylaxis. My question is, taking prophylaxis is still okay for intervention, or to have to take the intervention for the factor or agent? Thank you.
Let me try to clarify. What do you mean with the taking prophylaxis? Are they participating in the MDA program, or is it apart from the program? Apart from program. Because what I'm aware of so far, the recommendation is to take the MDA for example, 6 rounds. But I know, like, for example, in the research reported by one of Indonesian researcher, Partono, many years ago, a region in Timor has been implementing this mass drug administration for more than a decade, and they still have the transmission going on. So we don't know where the problem really lies on. Do they actually report the correct coverage, for example, or is it the drug is less effective? So in that sense, you can say that, okay, part of the annual MDA is actually part of the programs for eliminations, and part of it was prophylaxis.
Sorry,
yeah.
So it's not part of the MDA, but it's prevention for people not getting the filariasis. Yeah, but in the south part of West Java is still, I think, not an endemic, but the program is prevention by providing prophylaxis treatment. So this prophylaxis treatment is still okay for filariasis cases or not?
I cannot immediately say whether it's okay or not. I could only try to recode what the guideline is. So we know that in the beginning we should do some mapping to see whether the disease is prevalent, which is whether it's actually a problem in the area. If it is a problem, we should do the MDA. How many rounds, depending on the recommendations, because it changes from time to time. How many rounds you do need to eliminate the disease, and once you complete the MDA, let's say 5 rounds, you should actually do the pre-test. So it's like a screening, a survey to see. You take random sample in the community to see what is the proportion of people still getting infected, harboring the microfilaria. If the country failed to show that the MDA after so many rounds managed to eliminate the disease, they should actually go back again to the MDA program for additional rounds. And then, but if they do succeed, then they are declared as an area free of infections. So I cannot really tell, because I don't know by heart per profile of per region what's the status of the area you meant. But yeah, we should actually go back to the guidelines and then look at this, the status. Because I know in Indonesia, the areas, as I said, officially we are still in the second stage, that is starting but not at scale. Sorry. But of course, Indonesia is a very big country. One province might have well reached that state, but the other might have not started at all.
Thank you, Dr. Oei, for the presentation. My name is Aspia from Immunology Study Center, and I'm going to continue my master's study in next month. I would like to ask a question for you. So, infectious disease is not only plays a role as the primary source of infections. For example, in autoimmune patients like in SLE, they pose a higher risk to develop infection, for example, like tuberculosis as the comorbidity. And is there any significant difference between developing the model for primary infections and secondary infections? Because the prevalence of tuberculosis in SLE patients is quite high actually, approximately 11.4% after they are diagnosed with SLE due to the immunosuppressive therapy effects and etc. I think it could be very helpful if we can try to develop the prediction model for the secondary infection that could happen in autoimmune patients. Thank you.
Thank you for your questions. I know there's many research focusing on what is the role of having a co-endemic of comorbidity of TB, for example, of malaria even, in developing LF. I unfortunately didn't look at that particular research questions. The aim of my study at the moment is how do we quantify the morbidity in our model. So once we have the model running and validated, we can probably look into more detail into a more sub-specific group, such as people with SLE or with TB or even with malaria, whether the model is still applicable to that setting or to that populations.
Okay, any further questions? Well, let me ask, because I haven't asked yet.
Yes.
Talking about the lymphocyte, is there any authority, health authority in the country or certain area use it for like a policy or a program that they actually plan or design?
Yes, so lymphocyte has been applied multiple times, not only in Africa, but also largely in India. We have a very good research partner in India, so they made so many estimations of the infections, and they actually based their national guidelines on the lymphocyte predictions. I know that the lymphocyte has also been applied in Indonesia. I forgot the name of the project, but it's actually also ongoing collaborations. How big is actually the burden of filariasis in Indonesia based on these model predictions? And in future, I'm sure they will try to use the results, the predictions, to inform, to guide the policies in the national level.
Okay, I just like to underline that in this era where we cannot actually allocate money for the decision is not supported by the evidence, right? And your lymphocyte is actually one of the tools that we can develop as a scientist to inform the decision maker what's the best option or intervention. While we have scarcity, we always compete for the money, and we don't know where to allocate, right? And sometimes people didn't really rely on this tool. Okay.
Yeah.
So, but not yet in Indonesia, as you know.
Yeah, it's been implementing. And just try to share the current status. Just like in prediction models and prognosis research, there are actually also many models for lymphatic filariasis. Among them is what they call EpiFil, which is developed by the UK research team, and we also collaborated with them. So we want to see how well do our model, the lymphocyte and EpiFil, perform when we try to predict the transmissions in a certain area. So the research has been published. I forgot the detail of the paper, but it's been published, and the conclusion is that both models give a comparable predictions. So you can choose whether you want to use the lymphocyte or EpiFil. But the lymphocyte itself is actually been implemented. I can look up the detail and send it to you later. So they do really use the lymphocyte to predict the transmission in Indonesia, and this project is actually funded by the USAID.
Okay, I think we almost 12 o'clock, but if you still have any question about this, well, we can learn a lot that even from literature review. So basically, you didn't collect primary data, right? I mean, you just pull the articles. We can build something, right? Because in our school here, in our university, sometimes they have a debate about the students. That the students have to collect primarily the data for make a thesis or even master thesis or even the minor thesis for the undergraduate students. Is there any PhD students involved with your works, or as a postdoc? You are as a postdoctoral researcher, right? Is there any PhD student or master students working with you?
Yes. So our team consists of one PhD student, and she's doing modeling in the filariasis and also onchocerciasis, so any disease caused by the filarial worms, actually. So she did also what I what I just presented, but for the onchocerciasis. So she did some search and then tried to improve the lymphosim. Lymphosim is actually derivations of our model. We call it wormsim. So it's also a stochastic individual-based model that predicts the transmission by worm infections. So then we modify this wormsim, tailor it to a particular disease. For onchocerciasis, we call it oncosim. For the lymphatic filariasis, we call it lymphosim. Because of the time pressure by the try to reach elimination by 2020, we got a more funding, try to speed up the results, because we realized if we only rely on one person doing this work for a PhD project, that they will take easily 4 years or more. We'll never get it by 2020. So even though now we even know that we will not reach it by 2020, at least we try to speed up by having more postdocs. So I also work with like 2 different postdocs, try to speed up these predictions for the lymphatic filariasis. And also, I just want to comment about the data collections. Of course, is preferably we would like to have data collected primarily, right? But we also realize how burdensome for the resource, not only for human resources in collecting it, but also for funding. So I just want to say that even though if we don't have the primary data, you can still work with infectious disease modeling, because there's so many research out there. Of course, it would be best if you want to predict the situations in your particular locations, then it would be more reliable if you have data from that area. But let's say if you're really like in a condition where you have no funding for data collections, you can still make predictions using available data. In future, you will hope that the more data will become available in your area. They can use that to validate your estimate, the model estimate. And you can say, well, we can trust this model or not.
It's rare that physicians become mathematical modeler. Is there anyone who will be a mathematical modeler? So he's basically modeling agents.
Modeler.
Modeler, yeah.
I'm not a model, I'm a modeler.
Yeah. Any questions? We still have time. If not, so again, one more? Okay.
My name is Yuanita. I'm from the TB-HIV. It's not TB-HIV anymore. It's TB working group, actually. I would like to ask about mathematical modeling itself. Like, how long does it take for you to make it this big? Like, what's the ups and downs, and basically just how long does it take? Thank you.
It's very subjective, of course, but I have to say, I didn't build the model. The model has been developed by this group at the Public Health Department of Erasmus University more than a decade ago. In the beginning, they called it wormsim, and they realized the potential of this model to be implemented in different fields of diseases. So then they modify it and then try to apply it, and then they see like it works, because when they cross-validate it with the real data from the field, they see like the estimates are quite reliable. And I'm sure it took them really years to develop a model. But just as in prognostic world, in infectious disease world, there's also like hundreds of models available. So instead of building one, I would actually personally recommend to try to pick a good one, a reliable one. How do we know that? Well, it's hard. Of course, there are always publication bias and everything. But at least if you start your research by doing a little bit of review in the beginning to see which model is actually quite reliable, has been applied so many times and gives reliable results have been validated, then I would recommend to start with that one instead of begin from scratch, developing your own. Because it took me really like years to learn how to develop a mathematical model, a good one. Not just, okay, you have data, you develop, and you don't care whether it's usable or not. So I would say try to identify one and then start using it. And you can say whether or not that model can be applied to your setting, and if it's not, you can always find the next better one. And then, yeah, once you publish it, then people will be more aware, right? Which models should actually be used for a TB problem in a developing country setting. You will help the research community.
Okay, so it's depends, right? It depends on the money. Because if you have a lot of money, you just bring all people to work together and to finish. Okay, so I think we need to end this. And again, on behalf of Faculty of Medicine, Universitas Pajajaran, particularly Department of Public Health, I'd like to say thank you for your coming to share your knowledge. Hopefully, someday we can collaborate with good works for Indonesia.
I look forward to collaborate for future collaborations with UNPAD.
And you know, this event made available is based on good friends. So I'd like to say thank you for Bonnie to having them here, because I know Welling is a good friend of Bonnie when she took her master in Rotterdam a couple of years ago. So that is not babysitter. So Bonnie is a colleague of Welling, and it's so small world, yeah. Thomas is also alumni of Maastricht University, and I myself too. We have different years there, so we didn't meet each other. And again, if we can stay in touch, hopefully we can also share knowledge in the future and also share our works together. Okay, thank you, and please have applause for them for the lecture. Is there any dean here? I'm not sure if there are any. Maybe one of the faculty here, Dr. Ediana, can have a representative of the faculty. Please come. Please come, Dr. Edi. Yes. You also alumni from Leiden University here. We have a small token from the school, so please, and picture will be great. Just hold. Okay, thank you. Thank you.
Thank you all for your attention, and we're very thankful for this opportunity. See you next time.